Welcome to Managing Myeloma. My name is Dr. Robert Orlowski, and I'm the director of the myeloma section and the acting chair of the Department of Lymphoma and Myeloma at the University of Texas MD Anderson Cancer Center in Houston, Texas. One of the questions that I get fairly frequently is how would I define an aggressive symptomatic relapse and what drug regimens would be recommended for treating a patient who is rapidly progressing. This is an important question because we do typically see two different patterns. One is a slow biochemical progression, but no clinical symptoms, and that should be treated fairly non-aggressively. And please actually look on the Managing Myeloma website for a different discussion of that scenario. But if you have a more aggressive relapse, and by aggressive I would define that as somebody who has hypercalcemia or worsening renal function or worsening anemia, or they have either new bone lesions or previous bone lesions that are enlarging, perhaps extramedullary disease, for example, a new plasmacytoma or an enlarging previously present plasmacytoma, or if they have a rapid increase in the monoclonal protein or their free light chains in the serum or Bence-Jones protein levels. These are people with aggressive disease, and you do want to be equally aggressive back, or the patients will become rapidly more symptomatic. What you do, I think, of course, depends on what prior therapy the patients had and whether they are currently on maintenance or not. But in this kind of scenario, I like to introduce as many new drugs as possible, and these would be drugs to which the patient's myeloma has either not been exposed to at all, or maybe they've been exposed for only a brief period, such as during induction, and then they were not reused during maintenance. Examples of combinations that I think are very attractive in this setting: if, for example, a patient is progressing on lenalidomide maintenance, then options would be to use carfilzomib with pomalidomide and dexamethasone, and another option would be something like daratumumab with bortezomib and dexamethasone. If you have a patient on a proteasome inhibitor, and this could be bortezomib or ixazomib, for example, then I think, for example, either pomalidomide or lenalidomide with daratumumab and dexamethasone would be very reasonable. And I also like pomalidomide with elotuzumab or lenalidomide with elotuzumab, both with corticosteroids, for patients who are progressing on proteasome inhibitor-based therapies. Other combinations that you can think about would include panobinostat, which is effective and approved with bortezomib, but also very effective and maybe even better tolerated in combination with carfilzomib. I often also will use other drugs like bendamustine or cyclophosphamide or pegylated liposomal doxorubicin, usually in combination with proteasome inhibitors. And these are things that you can use for more aggressive disease. And the goal is to try to get control of the aggressive disease and either then take them on to either a first or second autologous transplant, or if that's not an option, try to get them down to the lowest level of disease possible, hopefully MRD or minimal residual disease negativity, and then maybe peel back some of the drugs and dosing to leave them on a more tolerable long-term maintenance type regimen. So I hope that this has been helpful in managing your more aggressive patients with relapsing myeloma, and thank you for viewing this activity.